Okay. Hi, Matt. Hi, Yuki.
Hello.
Hi.
Welcome. I would love for you both just to introduce yourselves and share a little bit about what you're doing now, what you're up to, and then I'll give some context on the work we did together, and then we can just sort of dive in.
Sounds great.
Cool. I can start. My name's Matt. I live in New York City. I work on youth mental health and well-being, a lot of more holistic programs, both in the US, then India, Kenya, a little bit in Colombia as well. We do a lot of work on things like meaning, belonging, and hope, and how inner development for young people can then support mental health, well-being, flourishing, and other things.
Amazing. And I'm Yuki. My work right now is really as like a steward and support for folks doing work in the birth justice movement, um, finding ways to support different midwives, doulas, birth workers. And currently in my role is around birth centers, particularly those led by Black and Brown folks and other folks of color, to really give them the tools to resource, sustain, and find joy in their work, as they're caring for all of our babies and our communities too.
All the babies.
Always.
Um, yeah. So as you can hear, we're in the presence of greatness, and we all came together not that long ago, actually, like in 2019, which I guess is almost a decade ago and also almost 5 years ago. Like somehow we're in that in between space in 2026. Um, and we were doing something called the Harvard Ministerial Leadership Program, and we were paired with the Federal Ministry of Health in Ethiopia because they wanted to roll out the first of its kind federal national level compassionate and respectful healthcare initiative. And so um, also known lovingly as the CRC initiative, which we came to say a lot. And so we spent about a month in Ethiopia, mostly in Addis, but going around as well. We did a lot of interviews. We talked to like different organizations at all levels. We talked to like hospital staff, community health workers, birth workers, patients, our BFF ER doc, Nahome, many others. And then we also like went to a lot of nonprofits and things like that. And we're just trying to get an understanding of, what are the barriers to implementing this type of initiative? And then also what are the like facilitators, like what's in place that could make this possible? And we also facilitated some incubation site workshops because the Federal Ministry of Health had set up some incubation sites, recognizing that like different parts of Ethiopia in different settings would need different ways of rolling this out rather than like a top-down approach of sort of this is the way we do it. This is what compassionate and respectful healthcare looks like. Ready, set, go. So that's the context we stepped into to do a lot of like listening and hearing stories and seeing themes. And then we created like a strategies, suggestions doc to support the national rollout of this program. And that's what we did. And it's sort of wild to think of like, so often like working with organizational level and they're like, we can't, do community listening. Like it's too messy. And it's like really a whole country did it. And like it was by no means perfect, but seems like, there's a lot of ways to do it. Um, and something we heard a lot was that like that, the nature of it as compassionate and respectful care, like that feels different to everybody. Like I might have felt like I had a great and compassionate interaction with a healthcare provider. And like Yuki, you might have felt like that wasn't so great. And like that wasn't what compassion looked or felt like to you. And then like vice versa. And so we heard a lot about how like measuring compassion and measuring respect weren't possible. So it had to be sort of this like lived, told experience of what it looks like and feels like and how it varies from context to context, culture to culture, person to person, bedside to bedside. Um, yeah, so I'll pause there with that background. And we'd love to hear just any like what stood out to you about this like approach that was taken by the federal ministry and that we supported and just like listening to all the layers of folks that we listen to create this like federal level movement.
I think for me, what originally brought me to the project, I had really understood the respectful care framework from the roots that it had in respectful maternity care, and discussions around human rights and childbirth and what it means to be cared for and treated well, uh, while going through different reproductive experiences. And then obviously, I learned a lot about how um, compassionate care was such a lens for palliative care. And it was really remarkable that like a federal government wanted to see this type of priority across the health system and see it like as an essential part of quality of health care. Um, because it felt like such a patient experience is such an aside when it comes to quality improvement. Um, that it felt really remarkable to be centering that, and for it to be such a priority. And I think what was really compelling about the work along the way was how much of what we learned and brought to the Federal Ministry of Health was around how not, in order for that care to be compassionate, the health system itself had to be compassionate to its providers, to its health institutions. And that was the only way that it like trickles down and like even reaches that individual interaction or sustained beyond. And so it was a really exciting project to be a part of as someone who was like quite disillusioned by health systems work, um, to see it be such a priority and to spend so much time, and resources really taking a moment to reflect, listen, and learn, at the federal level.
Hmm.
Yeah, picking up on the disillusionment, I feel like often health systems work is almost treated as like a technical, almost like math exercise of, there's these inputs, so then if you arrange them in this way, it'll lead to these outputs and outcomes. Whereas it was special being a part of an initiative that's very explicitly focused on things like compassion and respect, which are deeply inner, very deeply human things. And I really liked what you mentioned, Yuki, of it's not just something where the health providers have to tap into their inner worlds and create this boundless compassion, but it's also how do you tap into like the inner part of the system and make it compassionate as well. So it's special to be a part of that work.
Yeah. Yeah. And, and like so often it's what we hear across health systems and public health workers, like the providers we heard from saying, like the reason they got into the work is that compassionate care and is that connection. And then the systems that they are working within sort of make it feel impossible to access that because they feel drained of it. And, but like to reconnect them to like the reason they came to the work and like the work they want to be doing is that compassionate work and like that's the care that patients need. And so yeah, it then becomes this like systems level, like we can't do individual intervention by individual intervention of like small tools for increasing compassion, but more so like how do we transform a system that is rooted in this. And like I mean that's the such a huge question. It comes down to like resourcing and housing and education and it comes down to so many things, but it really was something that we watched and listened to um our colleagues like grapple with and allow to be complex and like it was just I think amazing to me to watch like somebody sort of take like a moonshoot um approach to public health and then also like grapple with the big questions without immediately trying to be like, okay, and this is the framework for increasing compassion in individuals and instead being like, who needs to come along in this? And the answer was literally everybody.
Yeah, we got to talk to literally everybody, and it was that I think there's something so special for this to be such a priority of a federal government and of a Ministry of Health because it is so central to how the rest of healthcare is provided, like across the ministry. And it sometimes did feel like we were in this cute little corner of this gigantic ministry, but then the stakeholders that we were connected to were so cross-cutting from like every level of the health system, um, outside of the health system, that it felt so foundational. And it felt like if Ethiopia would be able to figure this out, it could like transform care across every type of different department that existed in that ministry building.
Hmm.
Yeah, I feel like, I mean, we came in after there was top level commitment at the Ministry of Health for this initiative, but I can only imagine that leading up to that, there were so many debates and arguments around like, hey, is the return on investment for compassion and respect in the health system sufficient when we're facing all of these other problems that are much more easily quantifiable and like the cost effectiveness per dollar spent, you can almost like do that math equation. So it's yeah, interesting thinking about like how that emerged as a priority and then got the highest level of commitment.
Hmm. Yeah, for sure. And something, in thinking of like the math of it all, so often I think organizations, I think especially those like, looking at nation level health or even state level health are feel this pressure um to do that, to like move quickly and really formalize things in a way that allows for that math to happen. And then, but what we realize in practice is that it's actually often like when we then slow down and like build the trust first and like that sort of system that is human and humane and connected, that then like the rest goes faster and the math gets better. But it's really hard to like hit that pause to your point, Matt, of like what type of debates might have happened, like hit that pause and be like, okay, we're going to do this foundational work to then go fast later or go more like efficiently or effectively or any of the other public health words that want to be inserted there, rather than like keep trudging ahead in this way that like isn't quite working but still like allows for that math. And so it's just like the trade-off is huge. But like if you can like do foundational work and then be able to move at the pace and like that you want to, I think that just it the dividends are huge, but it's so hard to make that case, I think, so often. And somehow the FMOH did it. And then we were lucky enough to be like, all right, we'll talk to everybody and see what happens.
Yeah.
Yeah. It feels like really remarkable. It feels it's such an application of an equity lens when you are trying to build a health system that provides the care that feels like an add-on or like a second thought, because it is so easy to fall into this. We just need to focus on access, and there needs to be access across the country. But what does it mean to have access to disrespectful care? If, like, what is the purpose of access if it's to disrespectful care? And to build a health system around what is the best possible experience and outcome of care, and how can we build our whole entire health system around that? And what does that mean for where we'll end up and where we'll be when this is like 5 years out, 10 years out? What will it
Hmm.
actually look like for our care? And how much will we have solved along the way by taking this like slower, more thoughtful, and very patient-centered approach from the beginning?
Hmm. Yeah. Something you said at the beginning, Yuki, about like your how you came to the work with compassionate care in folks who are very like having different reproductive moments, experiencing particularly in birth, I think it comes up a lot, and then also in death and palliative care. And there's this like I guess in the waters I swim in, a common thought that, like how we approach birth and how we approach death actually have a lot to do with how we approach life. And so, like, seeing it in that way, I think just helped me re-see this in a new way, too, of like how we approach care at birth and how we approach care at the end of life is like how all care interactions throughout can and should feel and look. And again, comes back to like, and that's why so many people get into provider roles and provide, and like get into this work and community health worker work and then are sort of forced out of it by systems, not out of the work necessarily, but out of that, like what brought them to it and sort of forced to accept, like, okay, I guess, this will just be the reality of the system I'm in rather than why I came to the work. But like, yeah, I don't know. I just like that reframe was really helpful um, if we're bookending life experiences with this, like, how do we like sort of make that continuity? And I think that's ultimately what we heard so much about is like where that continuity was missing and where there were opportunities for it. And I think I was really interested and amazed in how, in the process and how we like heard people be really honest about the barriers, but really also honest about the like open doors. And then like the ministry being like, okay, there's an open door we can go through there, and like recognizing the barriers without being like, because of these barriers we can't do it, but like how do we creatively like step through these open doors to then like, almost like get like our like I don't know, I guess our foot in the door before we can get the whole body in the door, just sort of this like, how do we just like, like walk through them in creative ways that like move this forward in the ways it can move forward so that like as that moves forward, it maybe pulls the rest along without being like, we have to have all of that solved for and we can't move forward if there are barriers, which I think so often like stops the work. And that did not stop the work here. It was just like a true curiosity of like, what more can we learn about it to move it forward so that there is that continuity throughout.
Yeah, I think Ethiopia's health system has achieved some really remarkable things, like in general. And then when you look at the amount of investment and resources available, those things become even more remarkable. And I'm an outsider and don't know that much, but from what I've observed, like a lot of the big achievements of the health system have involved like really distributed ownership of the problems and really extending also beyond what's traditionally seen as just, doctor or specialist-led healthcare.
Yeah, and that was so evident too in who we spoke to, because you would, maybe think if in like a federal context, if you're going to look at rolling out something on a national level, that like you wouldn't like that the partners would almost be like pre-decided, and it wouldn't be like, okay, let's go to hospitals, let's go to health centers, let's go to like maternity wards, let's go, to nonprofits. And it was like they were all seen as true partners in it, to that like sort of decentralized point you're making. Um, and I think that made it really possible rather than being like, we need to figure this out here centrally and then distribute it. It was like, how do we have incubation centers? How do we like sort of create this web across the country of like folks and organizations putting their like their work, this work in a context that makes sense to them. And that's something that happens so often, I think, especially when we think about like going from an urban center to rural centers or even just different parts of urban centers, where it's like, okay, we'll just take that data and those learnings and just like copy and paste them here. And when we lose that context, we like lose sort of the essence of what this work is, which is like that hyper local, hyper contextualized implementation of what care and compassion looks like in that setting. And so it was just, yeah, amazing to watch that sort of allowance, if you will, of the many, many seats that were pulled up to the table to define what this meant and understand sort of the map and landscape of where it would be rolled out.
Yeah, and I think there's also this piece of like having autonomy over what this kind of work looked like, regardless of the site, because for some sites, I think, remember, you and I went on some site visits, and for some, it was like having clean facilities felt like the most important to be providing that compassionate and respectful care, whereas other facilities were thinking more about provider care and provider shortages too. And so, as you mentioned before, so much about compassion and respect is so subjective. And what does that mean for that to roll out so differently at from everything from like a corner health hub to a small regional hospital? It's going to look so different. and to have a Ministry of Health that is so supportive of that autonomy and figuring it out and willing to, as you mentioned, like incubate and assess and learn along the way felt really remarkable. I think to the point where when we got there, I think we had certain like concerns of how additive our work was going to be, um, given how much had already been implemented, how much thought had gone into where the CRC program was when we landed down in Addis. But I think it just speaks to this learning mindset and this growth mindset. And I know so much of what felt most helpful as we were leaving for us was like connections and examples of other state and country programs, but I also imagine like the space to connect, learn, and just stay in that like ideative space was also really helpful for the folks that we were connecting with throughout the ministry.
Hmm. Yeah, there's this to beat the drum I'm always beating, like in listening, it's like inherently a trust building exercise as well to like listen to the stories and experience of others, and like that trust lays the foundation for like more work to happen on top of. And so it was like, yeah, by like understanding the foundation, we're also like laying, I think, another foundation, like a stronger foundation too, of just like, okay, the ministry is like said they're here to listen, and now they're like, here they are doing it. And I think that that's like so often a misstep is like communities, including the providers who live in those communities, being able to watch and like see sort of lived examples of what they hear are like priorities for the folks who are making decisions that impact how they do their work and when they do their work. Um, yeah, and yeah, there was just like um, I think in terms of the commitment, and like I think something that struck me and is aligned through a lot of what we're saying too is like we did also see, like um immense and urgent need that was not being met while this was being made a priority, and like sort of that um there are the payoff, or not the payoffs, but like the trade-offs is, I guess, the word I'm looking for, of, always like when we prioritize one thing, another is not prioritized. And so I think that that was something that we all grappled with too, of this, like, this is incredibly important and the future impact is so big and the work has to happen now in a time where people still need access. And like that's just true for the work we're all doing always. Like there will always be the urgent need. And when we are always in that sort of like reflexive response to urgent need, we lose the ability to sort of like look at, what's causing this, and like what's behind, and like what are some of the ways we could reckon with or improve the like s- conditions that are creating this like continued urgent need. And so it's such a hard trade-off. And I know we've talked a bit about this, but just like in being there and in witnessing that trade-off and knowing still like this is a worthwhile effort because like it changes the trade-off down the road. But I just think about that in, as the factor that so often like stops this type of dreaming and scheming and stops this type of like big moonshoot project, is the like what about right now. And I think we saw a lot of like meeting the right now while going forward, and the understanding that like there's just some like white knuckling that happens when you're like going toward um outcomes and change and like full systems change. And like I think something that helped me get through and like grapple with that was just like that clear vision of like what it looked like on the other side and like how that was possible. And it can be hard to hold that, but I just felt like in those conversations there was like the ministry had done such an incredible job of like holding that vision and like sharing that vision so that we could all look towards it and understand that like, hey, this is where we're going, and there are mountains to climb on the way there, and we're going there anyway.
Yeah, that makes me think of, I mean, obviously no country or Ministry of Health is perfect. I'm sure that there are lots of issues with other parts of the system and with the work, but it's almost like in order to do something like the Compassionate Respectful Care Health Initiative, you need to be tackling the other things with a seriousness and an urgency. At the same time, I think that Ethiopia has still been, building towards national health insurance, universal health care coverage. And that makes me think of being situated here in the US. It would, if there was like a national compassionate respectful care initiative without any effort to have universal health coverage or to address health inequity, that would almost be like laughable
Mm,
or not taken seriously, and there wouldn't be credibility because there isn't accompanying urgency for some of the not maybe more easily like seeable immediate needs.
hmm
But the work on the CRC was accompanied by like a real urgency and radical action on the other issues.
hmm
Mhm. Yeah. Yeah, exactly to that point, Matt. I think like it makes me think so deeply about our efforts in the US around especially like racism in the experience of giving birth. And for many states, and I think the proposal for like a lot of federal legislation is to provide anti-bias training for healthcare providers. And it's such a downstream solution that it is like laughable and hilarious and feels like no win at all because it is so wrapped up into other structural change. And to have a Ministry of Health really recognize that, at least the folks that we were interfacing with and connecting with, recognizing that compassion and respectful care was meant to be throughout the system and structure of healthcare in Ethiopia felt really feels promising and hopeful. And it did not feel like it was the exclusive focus of the ministry and was really accompanied by um efforts, which also makes me wonder at one point is a federal health system able to integrate this kind of priority and yeah, at what point are you able to build that buy-in and move past like that immediate return on investment conversation to really prioritize this? And I think from the examples that we saw, I think it was like Jamaica and the UK as well had
hmm
prioritized these things. I wonder, yeah, I just wonder how and when it enters the conversation.
hmm Yeah, and that sort of like unknowability that we referenced earlier, like if we move this forward, like what else comes along? Like what gets solved in
Mhm.
that? And is it that, like, yeah, is health insurance somehow wrapped up in that, like, to be compassionately cared for is to know that you won't get a $2 million bill after the care. So it's like, yeah, and so that definition and that undefinability comes back into it as well. Yeah, and so we left Ethiopia and got back to Boston and spent so long. And like, like I think it just like was a testament to I don't know, just like analyzing what we heard and like making recommendations and based on what we heard. And I think it's like something that stood out for me is this sense of like, well, who are we to like make recommendations to a ministry? But that was like immediately um almost like canceled out by like, well, the recommendations we're making are based on only what we've heard from people who are there doing the work. And I just think that that's like I think that type of work of like listening and building story based on or building strategy based on story is just like it's protective against that sort of like interception of folks who maybe don't understand the exact context or things like that. Because it's like we were only recommending based on what we had heard and like what people who with lived experience had said, and not trying to be like, okay, this worked in Jamaica, maybe it'll work in Ethiopia, but instead, like, what is and isn't working in Ethiopia and where are the opportunities? And so I think that was just like an important part of it for me was just like we can do this work only because it is being guided by the people who are impacted most by it. Any other thoughts on our report and our strategy portion of this?
I think it felt really special and unique. I think also reflecting on other similar projects that our peers were doing with other countries' ministries of health, um, that our data was the stories that we gathered and what we heard, um, and what we had learned and heard from like experts on compassionate and respectful care in other contexts as well. Um, and for that to be so valued and yeah, considered a recommendation at all, just to be reinterpreting and resharing the stories that we'd heard, feels really special and important. I think, and a testament to what this kind of initiative centers. Um, I think, again, and maybe this was just me, but I did have like a small crisis of like, what are these recommendations if they're just affirming what the ministry is already doing? I don't think
Mm,
anything we recommended was absolutely out of pocket or off base of like what work was already happening. And
mhm,
and I think for us as folks who had poured so much energy into this project, that felt like so counterintuitive or that we hadn't made progress on the project. But I think that in and of itself like spoke to the strength of the initiative already, um, and also the support and the consensus around like what needed to change and what needed to happen to really make this initiative um, as successful as possible. And so I think that's what I would tell Yuki and team of 7 years ago of like sometimes it is just affirming. Um, yeah, sometimes the recommendation can be to just affirm and uplift those
mhm,
stories.
mhm,
I remember that a lot of the interest from the folks we were working with at the ministry was on the measurement piece. And so we spent a lot of time like talking to experts and looking at measures, and also sort of the outcome or the output of that was like, hey, here's a bunch of measures that are out there and they're all like deeply flawed and imperfect. And so just need to figure out how to deal with that or to triangulate from different sources. So that was an interesting of like that was a key gap that they were highlighting, and also the solutions that are currently out there or considered best practices, especially in more Western contexts, are just so inadequate. And
mhm,
there's, yeah, a gap between what we wanted, what everyone wanted to do, and what was available.
mhm. Yeah. Which I think then further turned us to, well, this is what we heard. It's so like that, looking outward for that just further turned us to like, okay, well, what we've heard from this context, and from the people we've spoken to brought us to this recommendation rather than like using another tool from elsewhere as well.
Yeah.
Yeah. Okay, fam. Anything else?
I don't think so. It's wild to reflect on something from 7 years ago.
Mm-hmm.
Yeah.
Um, and it's already making me noodle on like what are the different streams that got us to each where we are now, that like we're
Mm-hmm.
so rooted in this what what now feels like a blip, but in the moment felt so serious and so
Yeah.
massive.
Right. Yeah, and I just think about like at the beginning when you're doing intros, like obviously like you both are so dear, such dear friends and colleagues, and like hearing, in Matt, the words you were using about like flourishing and things like that, of like also these sort of like hard to um define but like deeply felt realities that we want in systems and in wellness, and in Yuki, the work you do, that it's sort of like, yeah, it made me just think again about this, like, one, I'm still in looking back on it and talking about it, even it's just like, I think it's just incredible that we got to do this, and just like sort of wild that like this was a part of the work we got to do. And then also yeah, it seems to still be very present in the work we're all doing in some ways, which is just really interesting, and yeah, might forever be some of the coolest work I ever get to do.
Yeah.
Who
Yeah,
knows?
the threads are interesting. Our conversation reminded me that I owe someone an email at, I think, Emory University, and they're like the compassion shift, and they're working with the Dalai Lama on how do you support compassion-based education in countries around the world. And so a lot of my current work actually
Mm.
is with experts on compassion from a bit of a different lens, a lot from the more contemplative and mindfulness and other things. Yeah, it's interesting to see the threads that have been woven through our careers.
Hmm.
Mhm.
Yeah, watch this space. We'll check back in every 7 years and see what's come of this
What
time
else
that we
we've
spent doing.
learned?
Yeah,
Yeah,
exactly. Who
maybe
we
we'll,
are now because of ABU.
yeah.
Yeah.
Well, thank you both so much for the time and for doing this together and spending some 7 years later time reflecting on it.
What a sweet time.
Thanks.
Yeah. Bye.